morning, everybody. My understanding is that the podium was meant to get used all day yesterday, but the first speakers started without it and everyone else followed suit. So they asked me to start at the podium this morning and set the trend for everyone else today. My name is Gail B.Broder, and I work with the HIV Vaccine Trials Network. During the COVID pandemic, Dr. Fauci redirected our efforts and we became the coordinating center for the COVID-19 Prevention Network. And my office was the coordinating center for all of the federally funded COVID vaccine studies in the United States. We're located at the Fred Hutch Cancer Center in Seattle, and our funding comes through the National Institute of Allergy and Infectious Diseases. I say all that because I want to be clear that my remarks today are my own perspectives and are not necessarily those of my employer or my funder. These are interesting times that we live in, and I'm actually, uncharacteristically for me, going to rely on my speaker notes because I'm still learning new vocabulary about what language I'm allowed to use, and I want to make sure I get it right in this new political climate. I think I may be the only social scientist attending this meeting, so I encourage you to relax. I'm not going to overwhelm you with immunology data this morning, but instead I'll encourage you to think about how the work that we're doing in the HIV vaccine and COVID vaccine space might apply to what you all do in your respective work. So thinking about this idea, community engagement, community involvement, what do we really mean? All facets of research, from its most early conceptualization through the dissemination of results, have largely been driven by the scientific community and often have very little or no community involvement. The sharing of scientific data and information has been restricted to peer-reviewed scientific journals and meetings like this, which create barriers to access for the larger public. And within the context of this environment, several social and structural realities have contributed to the widening chasm between us, academic and medical professionals and the institutions we work for, and them, the general public. And to build trust and confidence in science and effectively address this misinformation public health crisis, our actions and commitment to the inclusion of communities are needed. Relationships build trust and ownership in science and drive the shift in perspective from being experimented on to feeling included. We move from people questioning whether they'll just be treated as guinea pigs to instead feeling like they are partners in our research endeavors. And this is perhaps the most foundational principle. We do not do research in or on communities. We do research with communities. And this is our goal. Until people feel fully engaged and see themselves as valued partners integral to our efforts, the us versus them mindset can continue. This idea, having the community seated at the table and involved in all of our operations, is rooted in an ethics guidance entitled Good Participatory Practice. While it was originally written for clinical trials of biomedical HIV prevention modalities, it has since been adapted to a number of other contexts, including TB, COVID-19, and other emerging pathogens. I've included the website here where all of these documents for all of the different diseases can be accessed, and these are free resources. In a rather timely announcement, just today, the WHO has released a new guidance, Resolution 75.8, entitled Strengthening Clinical Trials to Provide High-Quality Evidence on Health Interventions and to Improve Research Quality and Coordination. And as part of that new guidance, one of 7 articles that comprise it is an article speaking to, in fact, this idea of community engagement. So I encourage you all to check that out if you get a chance. Hot off the press. So it's important to remember the history of vaccine campaigns. These are photos from the 1950s during polio vaccine rollout. And one of the questions that we continually ask ourselves in the HIV space is, does anyone think that when we have one day an HIV preventive vaccine to distribute to the public, do we think that there will be people lined up down the street waiting to get their vaccination or bringing their children to get their vaccination? Instead, what we are confronted with is the stigma, the homophobia, the transphobia, and all the other structural barriers that drive the HIV epidemic and make it seem unlikely that we would see this sort of public acceptance for the rollout of a preventive HIV vaccine. Think about what you've heard and experienced during the COVID pandemic, and even perhaps what you've been seeing lately here in the US around measles vaccination. As you look at these photos, consider what is the legacy of this history and how has it brought us to where we are today. As you look at the photos, do you see any people of color represented in these photographs? How does that historic exclusion contribute to the current environment where we have lesser involvement and uptake in these marginalized and underrepresented communities? You might recognize this image and this expression from the film A Field of Dreams. And while the catchphrase may work for a fictional baseball diamond in a cornfield, does it hold true for research? If we build it, will they come? We find that sometimes scientists seem to think that it is really just that simple. We have a concept, we have a product, we design the clinical trial, we open it for accrual, and people just magically sign up. But the truth is that it is rarely that simple. And in my environment, working in disease prevention, it is never that simple. In a treatment trial setting, as we've heard about yesterday, individual volunteers may be motivated to participate because of a desire to address a health condition that they themselves are experiencing or a family member is experiencing. And that certainly holds true in the cancer arena, and others have presented about that. But in the prevention research space, we enroll people who are healthy and ask them to take experimental products, sometimes in first-in-human clinical trials, where we don't even know all of the risks to inform them. We can't go to doctors and ask them to refer their patients to us because most healthy people aren't routinely going to the doctor, maybe except, a once-a-year well visit. So we need to tap into the public spirit of altruism, the desire to give back to our communities to benefit others in the future. Most healthy people have never considered joining a clinical trial, and they may not even know anyone who's been a research participant. So we need to spend a lot of time laying the groundwork to help people understand the importance of getting people involved in research. But as this sample of recent headlines in scientific publications would suggest, discussions about science are no longer limited to the ivory towers of our institutions or of the carefully peer-reviewed publications that we all seek publication in. Both the U.S. Surgeon General and the World Health Organization have declared that health misinformation is a threat to public health. The forces and the factors that empower misinformation include our general populations being overwhelmed by information, certain entities benefiting from disinformation, the growing social division and political polarization in U.S. society, and the continued erosion of trust and confidence in longstanding institutions. However, these discussions rarely focus on the precarious relationship between the general public and science. In my HIV vaccine work, we have found that relationships are everything. The quality of the relationships drives interest, drives enrollment, supports retention, and communication to others regarding research. Within the context of this contentious environment, social and structural realities have contributed to widening this chasm between us and them. When we engage communities, it looks more like this, moving people along a continuum, from a place of perhaps having no awareness that research is even taking place, let alone at a center that might be in your own community just up the street, to a place where they can actually integrate information into their own lives and take action. If community engagement efforts are being implemented successfully, communities move along this continuum with an outcome of active trial participation, participation in a community advisory board, supporting their friends and family to become trial participants, as well as general support for a research agenda. In our clinical trials, participants have reported that the relationships they establish with the clinical research staff have supported their decision to enroll, have supported their participation and the decision to continue coming back for all of their follow-up visits and adherence to the study schedule, whatever that may be, and retention in the study. So how do we do this? How do we build relationships that support community buy-in and build that sense of assent? We begin with informal focus groups. This could actually be one of the things that a community advisory board could help to serve that purpose. And you may recall I asked this question of our panelists yesterday morning. That sense of consultation helps us to understand some of the major concerns that any particular community is dealing with. Then we must move to consulting the general community and assessing possible solutions. It's important to identify any gaps that perhaps you or the community have overlooked. And at this point, the research staff can coordinate a plan to ensure that there is, in fact, community assent, a process that includes creation of a formal community engagement plan. At this point, you might think that you've finished and that you've reached your goal of having the community's buy-in, but instead, we actually start over and we continue to iterate on this circle because we realize that every time we think we've finished, there is some different segment of the community remaining to be consulted. That might be a particular population, a different geographic neighborhood, some other community that is related, and we continue to have to iterate in this space to always continue to build that community involvement. It's also important for us to remember that our research participants are only at the research clinic for a limited period of time over the duration of a study. They spend the majority of their time living their regular lives. They live in the communities, wherever that may be, and they're influenced by all of the factors that I've mentioned, including that misinformation and the polarization that exists around us. Our research site staff must ensure that study participants understand all the risks and benefits of participation and be prepared to answer all of their questions. However, when they leave our clinical spaces, they talk about the study with partners, family, friends, others who are highly influential in their lives. And where do these trusted voices get their information? Often it is from mass media outlets such as the radio, television, and the internet, where there is no filter against those myths and misinformation. By seeking to educate this wider community and not only those who may be appropriate to participate in our clinical trials, we can be more confident that the interactions between a potential participant and the trusted voices in their lives will reinforce more truthful and accurate messages. An informed community can become engaged in the study, which increases the likelihood of successful recruitment, supports better retention of those who enroll. So when and whom do we educate? And whenever I get asked this, my answer is everyone, all the time. We are never done. Researchers and medical providers who approach communities as partners and contributors to the research, to the treatment and care and prevention services that they need, are more successful at building and maintaining these relationships of trust. Cultivating strong relationships also requires the creation of spaces that are welcoming and affirming to support the inclusion of diverse populations. I think back to an interaction that I had with a clinic that we were working with in Puerto Rico that was based in a center focused on maternal and child health. and their waiting area and the clinic space was all pink and rosy and feminine and had photographs of mothers and smiling babies. And now they wanted to start enrolling gay men in their studies of an HIV vaccine. And they couldn't understand why no one was coming to the space. Why are we having so much difficulty enrolling? And I went to visit, and my first question was, why did you think gay men were going to feel welcome in this room? There's nothing here that speaks to them. There's nothing that says in this environment that when men are welcome, or that we understand your culture or understand your needs. So thinking just about the creation of spaces that are inviting to the people we seek to work with is really key. In the HVTN, our model includes the incorporation of communities into every aspect of our operations. Every research protocol, every working committee, our governance committee, our evaluation programs, every aspect of our organization includes community advisors as equal partners working in those efforts. The team members work together on our research protocols, on any of the public-facing materials, on informed consent materials, and everything else we do. And then as we get to the end of the line, when we actually have results to disseminate, whether they're favorable or unfavorable, the dissemination of results historically has focused on sharing data through peer-reviewed publications and in conferences like this one. And although there have been notable changes, many journals are not even available to the public. Many of them require subscriptions. And then even if you do read the paper, they're typically not written in a manner that makes the information very accessible to the lay public. The jargon, the technicalities, how to read the scientific graphs and charts, all the acronyms that we speak with. This is not language that is well understood by anybody who hasn't been through medical school. We all need to consider the other ways that we can be intentionally inclusive with the public to share our findings and using language that is free of jargon that they can understand. And yet, try as we might to do things better now in the present, it is also true that things have not always been done well in the past. And the legacy of past ethics abuses in research live on and contribute to the lower rates of participation among Black, Indigenous, and other populations of color or BIPOC persons. In a paper that my team published about our experiences with recruitment for the COVID-19 vaccine trials, from which this is a figure that I excerpted, we shared this figure that showed data from the first 4 of the federally funded COVID vaccine studies from Moderna, AstraZeneca, Janssen, and Novavax. Of note, contrary to what you might have heard reported in the news media, what we saw was that Black and African American enrollment, which is shown in the red bars on the left panel, was constant across all the trials. Hispanic enrollment, shown in green in the center panel, was also constant, approaching 1/4 of the enrolled participants. Overall, the BIPOC enrollment, shown in purple on the right, was also constant with averages just below 50% of enrollment. One of the other notable things that we are quite proud of was that there was an increase of American Indian enrollment in the Novavax trial, which is shown in the darker blue bars at the very top of the left panel. That study started about 6 months later than the first to open, Moderna. Moderna opened in July of 2020, Novavax in December of 2020. And that additional 6 months allowed us to engage tribal leadership in a variety of consultations, to reach agreements about data sovereignty, and to negotiate publication rights so that they felt in control and a sense of ownership over the data from their own community. This engagement resulted in an increase in tribal support, and we had a statistically significant increase in Native American enrollment in the Novavax study. Having that additional 6 months of time for engagement mattered, and the enrollment showed the favorable result. But what got reported in the media was that there was low BIPOC participation. We heard time and time again, Black people aren't involved, Hispanic people aren't involved, and so on. But the real story was that BIPOC enrollment was constant and quite steady over the study duration. It just happened at a slower and lower rate than the white enrollment. And in fact, in September of 2020, about 60 days after their study began, the Moderna group instructed the sites to stop enrolling white people because they recognized that the pace of enrollment among the white population was going to outpace their ability to have a statistically meaningful sample of people from minority races and ethnicities, rendering their data perhaps not effective to prove anything for how their vaccine worked in minority communities. So that sensitivity to who you're enrolling and the pace that you're enrolling really supports the notion that we need to build consistent expectations around how many people from different groups need to be enrolled in our study in order to achieve meaningful data for the populations we serve. And similarly for Novavax, the white enrollment was outpacing BIPOC enrollment, but again, BIPOC enrollment was steady over the trial, and as I mentioned, our rate of enrollment of American Indians increased in a statistically significant way. The take-home message here is that even with robust fiscal resources that were available to us in COVID research and the long-standing collaborative and collective efforts of our affiliated research sites, the enrollment of historically excluded communities, although steady and consistent, is often slower. And in the absence of having established some sort of recruitment goal, the allocated slots are likely to quickly fill with the majority population, which can effectively block the members from those underrepresented communities to participate. This fuels the perception of exclusion and that research is untrustworthy or somehow not intended for some groups. Depending on the nature of your work, determining statistically relevant levels of participation by people of different sexes, different races, ethnicities, age groups, socioeconomic strata, and so on. All of these demographic metrics matter, and they are key to achieving inclusion of a meaningfully diverse cohort. And it is our task to think proactively about this and plan for it. Finally, I want to leave you with some suggestions for concrete action. First, we need to move beyond recommendations about inclusion and instead move to action, setting clear requirements for the inclusion of populations that do represent the different impacted groups in your clinical trials. Funders will need to lead these efforts, moving from recommendations to requirements for such diversity. Next, meaningfully include the community in the planning and implementation of your research. This could be as consultants, co-investigators, or other significant contributors. It often requires capacity building to ensure that both community partners and researchers have the skills that are needed to collaborate in successful ways. Third, establish community relationships as the norm in your setting. This requires capacity building for both scientists and their institutions to ensure cultural humility and the use of effective communication skills. It also requires education of the institutional review and ethics bodies to recognize that community members can be equal partners in research. Number 4, care about a population's whole health and not just the one aspect that is part of your research agenda. Recognize that your patients and participants come to you as multifaceted individuals who have many needs. And finally, work to address those social and structural factors, whatever those needs may be, including housing, employment, access to quality health care, the stigma and discrimination that they experience, all of which can impact health and well-being and can also perpetuate marginalization. Incorporating these interventions and addressing these factors in your research rather than treating them as confounders or extraneous variables. This will involve working with funders to ensure that the monies available to you are permitted to be used in this manner, and you may need to seek additional funding beyond the specific health issue of interest. You may also need to consider bringing on a social scientist as a collaborator or co-investigator. We want to work with you, I promise. To conclude, the importance of community engagement is to ensure that science is responsive to community needs and interests, which provides an added value to science itself. If the science is not responsive to the community's needs and interests, then our advancements and discoveries will likely require significantly more effort and resources in order to build support for the eventual uptake of such interventions. By ensuring involvement early in the process and through building ongoing partnerships, we build efficiencies and time and resources that are gained when implementing interventions for large-scale public health impact. We believe that informed communities contribute to greater scientific advancements, and when community members are partners in the research, the clinical trials can be more easily accepted and supported by communities. To accomplish this goal and maintain these standards requires all of us as research staff to work with the communities we serve and to understand how the community's roles intersect with compassion, humility, and sensitivity. In these polarized and increasingly challenging times, I want to encourage you to bring your humanity to work every day. I want to thank you for your kind attention first thing this morning. I want to acknowledge my team and our leadership, as well as our global research sites that we work with who bring our research to fruition. We could not do this without our clinical trial partners around the world. We currently operate in several nations on the African continent, several nations in Latin America and in Asia. These global partners are a significant contributor to our success. I'm not sure what the plan is for making our slides available to all of you, but I did include the citation for the COVID paper in case anybody wants to see it. And I thank you this morning. Happy to take questions.
We have time for one question.
I like very much this talk. Thank you much. And absolutely close to me that involvement of the communities are very important. But there is a hot potato.
Indeed, there always is.
What is the perspectives presently for the future of the communities who want or not want to involve? So what are the point in this present regime that what will happen later on?
Yeah. One of the things that we talk about routinely and that we take a lot of attention to is that when we work with our community advisory boards, we remind them that the A is advisory and not activist, that we have to be activists in whatever manner we wish on our own time, and that when we're in the research space, we are there as advisors. And so we keep the focus on the science front and center. But as I was sharing with someone in a conversation yesterday, we had one study that we were working on where the initial proposal was to have participants undergo lymph node biopsies, a fine needle aspiration. I believe it was 4 or 5 times over a 12-month clinical trial. And our community member spoke up and said, do you mean all of the participants who enroll will need to do 4 or 5 of these biopsies? And the answer was yes. And the community member said, is it not possible to do that with a subset of participants? And the vaccine developers said, well, why would we want to only do a subset? And the community member said, well, I don't know very many people who have control over their work schedule such that in this 8 or 9 month period of time, they could take a day off of work that many times to undergo this procedure. So if you only wanted to enroll a group of white people who work in executive level positions where they can just decide, I'm taking a day off, okay, you could do your trial and that's who you'll enroll. But if you actually wanted to have people that work in a variety of settings, men and women, people who are students, people who have families, people who may work in other kinds of employment, you're going to have to relax this in some fashion to make it possible. And the researcher literally sat there sort of dumbstruck. It had never even occurred to him the amount of time involved to incorporate that procedure. So even advice like that, you know, it just opens people's eyes to things we haven't considered. And it doesn't necessarily always mean that the advice that's given can be accepted. And the community members need to know that it's a two-way street. Sometimes the scientific need overshadows. But you have to build that relationship of trust where that dialogue can occur, or we'll never learn what matters to people. Thank you. It's a beautiful question. Thank you.
Thank you, and we'd like to present you with a certificate.
Thank you so much.